Hello, class. This is Chapter 17 on the cardiovascular system. All right, so let's look at our objectives. And when we think about the objectives, we are going to be understanding the normal anatomy and physiology of the cardiovascular system, and we'll look at risk factors and incidence of cardiovascular disease. We're also going to look at how we can teach our patients to modify risk factors, things that increase their risk for development of cardiovascular disease. And we're also going to talk about how can the nurse help when we talk about our patients with cardiovascular disease. We're going to talk about diagnostic tests, techniques, and procedures for assessing the cardiovascular system. And we'll look at some nursing diagnoses for patients that have cardiovascular disease and look at the expected outcomes and the appropriate nursing interventions. In a clinical setting, hopefully you're doing this in your clinical, you'll be able to teach your patients about any cardiovascular issues, test procedures, and do some teaching about cardiovascular disease, and also assess any cardiovascular abnormalities that you see in your patients. So let's talk about the heart itself. When we think about the heart, I want you to remember that the heart is a four-chambered pump. And I'm going to bring a picture over so you can take a look at the heart as we discuss. So I want you to think of the heart as a four-chambered pump. There are two atria that are on the superior or the top part of the heart, and two ventricles that are on the inferior or below. The lower parts of the heart, and the heart itself is divided into two halves, left and right, by a muscular septum. And so I like this diagram because it kind of shows you the flow of blood through the heart. And so understanding that deoxygenated blood comes through the vena cava. We have the superior and inferior vena cava, and those are the largest veins in the body, the vena cava. So there's a superior, meaning above the heart, inferior, below the heart. Then that molecule of or that drop of blood goes from the vena cava to the right atrium. It goes right through the AV valve, or the atrioventricular valve, and it's also called the tricuspid valve, into the right ventricle. Then from the right ventricle, that blood will be forcefully pushed to the pulmonary valve, and it goes right through to the lungs. From the lungs, while in the lungs, that blood drops off carbon dioxide and picks up oxygen. Now it's richly oxygenated blood, and that blood returns to the heart via the left atrium. So that blood that comes back to the left side of the heart is oxygen rich. The blood on the right side of the heart is oxygen poor or deoxygenated blood. Okay, so that left atria has now oxygen rich blood. It passes through that left atria, then it goes through the bicuspid valve, and sometimes that's also called the mitral valve. And then it goes into the left ventricle. From the left ventricle, the blood is forcefully pushed out through the aortic valve, then to the aorta and to the rest of the body. Okay, so that's the kind of the blood flow through the heart. So the heart is a four-chambered pump, and we're going to get into details about the cardiac cycle, ejection fraction, and so on. So this picture kind of gives you also a view, and it shows the blood flow from the into the heart through the vena cava, then through the pulmonary artery to the lungs. Then from the lungs, it comes back to the left side of the heart. And remember, the left ventricle is the most muscular, the largest chamber of the heart, and the blood is pushed forcefully to the rest of the body. Okay, so that is your oxygenated blood flow. Now, when we think about the cardiac cycle, it consists of contraction, of the cardiac muscle, which is also known as systole, and then relaxation is diastole. So systole is contraction, diastole is relaxation. Remember, your heart is pumping about 5 liters of blood every minute. So think about how much is a liter. When you think about your 2 liters of soda, so 2.5 of those, your heart is pumping every minute. Now, the amount of cardiac output is going to depend on the heart rate, how many times per minute the heart is beating, the amount of blood returning to the heart, and that's your venous return. So if there's a blockage or if there's issues with the patient's veins, that blood amount that's returning to the heart is going to be decreased, right? So that's why if your patients have edema of the lower extremities, we say elevate those extremities to promote blood flow back to the heart, because that's going to affect the patient's cardiac output. So cardiac output depends on the heart rate, again, how fast the heart is beating per minute, the amount of blood that is returning to the heart, that's the venous return, and then the strength of the contraction. How strong is the heart beating? The other thing that determines the cardiac cycle and the cardiac output is the resistance to the ejection of blood, the pressure in the arterial system. So if your patient has a condition called arterial sclerosis or atherosclerosis, that means they have plaques build up in their arteries, and that's narrowing those blood vessels, and that's going to create more resistance. Then the patient's going to have less of a cardiac output. So it's really important that you understand these pieces, because each of these pieces can affect the patient's cardiac output, which will in turn affect how oxygenated blood gets to the body, or if it doesn't get to certain parts of the body. Okay, so the ejection fraction, this is blood that is actually ejected or pushed out of the heart during systole. Remember, systole is going to be that contraction of the heart. Now, a normal ejection fraction is about 50 to 70%. Okay, so that's going to be enough to perfuse, to bring oxygenated blood to the rest of the body, the cells and tissues of the body, all the way down to your tippy toes, all the way to the top of the head. That's going to be important. We need that normal ejection fraction to be 50 to 70%. If your patient has heart failure, then this ejection fraction is going to decrease over time. Now, the problem with that is, besides not getting a proper perfusion or the tissues not getting what they need, this can cause a backup of blood in the pulmonary vessels. So this is going to affect the lungs, okay, the lungs. Too much blood in the lungs can cause pulmonary edema. So these vessels will have increased pressure, and the patient will have pulmonary edema. And so this patient will also have difficulty breathing. And so that will really affect their ability to oxygenate the blood, and the outcome is not necessarily the best for this patient. They'll have difficulty breathing, shortness of breath, even when they're getting up, going to the bathroom. Okay, now your cardiac output is going to be equal to that stroke volume multiplied by the heart rate. How much is being put out and how many times per minute is the heart actually beating? So that's going to equal your cardiac output. Okay, so this is a fancy picture showing you the heart from two perspectives. From the right perspective, and then they will actually remove the first layer of the right side of the heart, so you can actually see inside the left portion of the heart. So when we think about the cardiac conduction system, I want you to think that the heart operates off of electrical impulses. And the first stop on that conduction system is going to be known as the pacemaker of the heart. Okay, the pacemaker of the heart. And so this pacemaker is the A. Wait a minute, I'm sorry. No, 1 second. Okay, I'm back. So when we talk about the heart has its own electrical conduction system, and it's important to understand that these electrical impulses help the heart to stay within a normal rhythm. So, and what we mean by that is that's your lub dub, and we have 4 spots on this electrical conduction system. The first spot is going to be the sinoatrial node, also known as the SA node. Okay, so when we think about, let me see if I could annotate on the screen. So the first spot is the sinoatrial node. The next is going to be the AV node, atrioventricular node. Then we have the bundle of His. Okay, and see these are the branch fibers, and then we have the Purkinje fibers. Okay, so these are the stops on the electrical conduction system, the electrical impulse that goes through the heart. Okay, so that's kind of important to know that when we think about a patient that is, not having a normal cardiac rhythm, they may have issues with the SA node, which is known as the pacemaker of the heart. Let's see. And so if they have issues, that patient may end up having a pacemaker, or if there's something irregular or abnormal, depending on the cardiac rhythm, the patient may have to have their heart shocked or defibrillated back to a normal rhythm. Okay, and that was with the case with the young football player Lamar Hamlin, I believe his name is. Okay, so when we think about blood flow through the body, we have 3 vessels that make up the vascular system. So we have arteries, veins, and capillaries. So the arteries are responsible for transporting blood away from the heart. Usually arteries have oxygenated blood, except for the pulmonary artery, but that pulmonary artery is carrying the blood to the lungs. Now, veins, they carry oxygen depleted or deoxygenated blood back to the heart for reoxygenation by the lungs. So when that blood is taken to the lungs, it drops off carbon dioxide and picks up oxygen. Now the arteries, they branch into smaller vessels that are called arterioles, and the veins branch into smaller veins, which are called venules. Now these venules and arterioles, they are connected by capillaries. Now the capillaries are the tiniest of blood vessels, and they serve to transport oxygen, and this is where the red blood cells have to go through single file when they're in the capillaries, but that's where all the action happens, in the capillaries. All right, so let's talk about the blood pressure. All right, so when we think about a patient's blood pressure, we think about the systolic and the diastolic pressure. That's going to be your lub dub. And so that's going to be important. Remember, the systolic is the contraction of the heart, and the diastolic, or is the diastole, is when the heart is relaxing and actually filling up with blood. Okay, so we also have a RAS system, which is your renin, angiotensin, aldosterone system. So I won't go into detail about that particular system, but what you need to understand is that system, the renin and angiotensin system, works with the kidneys in order to maintain normal blood pressure. So that's why a lot of times if your patient has abnormal or out of range blood pressure that's really high, they can end up with kidney damage. So that's going to be important to understand. The sympathetic nervous system is behind it all. And so the sympathetic nervous system helps to provide these impulses to help to maintain the normal blood pressure. And then the atherosclerosis we just mentioned earlier is the actual clogging of our arteries due to plaque buildup, too many fats. If a patient has high cholesterol, if they have a high fat diet, they increase the risk of atherosclerosis. Okay. So women and heart disease. So unfortunately, women are increasing day by day. There's more and more heart disease in women due to many things, due to increased stress, due to not enough physical activity, due to being overweight, also having other comorbidities like diabetes. So really, it's important to educate our women, and there is the Go Red Foundation that serves to educate women and talking about healthy cardiovascular choices. So walking, low sodium diet, all of those things can be, taught to our patients. So let's talk about the warning signs of a heart attack. So this is a classic kind of thing that your NCLEX questions will be made of. So chest discomfort, the patient may say they have a feeling of tightness or pressure, a crushing, squeezing pain, lasting more than a few minutes. And what you may see. Okay, so just to review, the warning signs of a heart attack. So this is where the patient is going to say they have discomfort, tightness in their chest, pressure, crushing, squeezing pain. In women, the discomfort is more in the middle of the chest, and sometimes women may not even have pain. And diabetics also present differently as well. So that's something to think about when we talk about heart attack. So the pain is what we call referred pain, and so the pain can radiate or spread to the arms, particularly the left arm, the shoulder, the back, the neck, the jaw, the top of the stomach. And women are often thought to have jaw or back pain. So those are some of the classic signs. The other things that you may see in your patient is that they may be diaphoretic or sweating. So those are all going to be those clinical cues that you have to look out for. The patient may also complain of having shortness of breath with or without chest discomfort. They may have a cold sweat, nausea, lightheadedness, with or without chest discomfort. They have a feeling of impending doom and chest pain that is not relieved by doses of nitroglycerin. Think about nitroglycerin. If the patient has angina, they may be prescribed nitroglycerin, and it's usually in this case sublingual, given under the tongue. And they'll take a first dose, and 5 minutes later, take the second. 5 minutes later, take the third. So it's 3 doses over a 15-minute period. And after the first dose, they need to call 911 because we don't know if this is just angina or if this is actually a heart attack or myocardial infarction. Some things to consider about nitroglycerin: it must be kept in a dark container. Out of the light, and it has to be in a cool room, and it must be changed out every 6 months. Okay. So here's some risk factors for cardiovascular disease. So non-modifiable things that we can't modify, we can't change. So we can't change our genetics, what we inherit. We can't change our race, our sex, or our age. Okay. Things that we can change or modify is obesity. We can diet and exercise. We can manage our cholesterol with the use of diet, exercise, and even medication. We can modify hypertension, diabetes, cigarette smoking, sedentary lifestyle, excessive stress, excessive alcohol intake, and cocaine use. We can change all of those things that are considered modifiable. Let's talk about metabolic syndrome. So, metabolic syndrome really it can lead to a lot of other problems in our patients. So I want to bring up a visual aid of metabolic syndrome because that will kind of help you get a picture of what's going on with your patient that may have metabolic syndrome. Okay. Okay, so here is a patient that here we go. Here's a patient who's at great risk for metabolic syndrome. This patient has type 2 diabetes. They have excessive urination, that's polyuria, excessive thirst, polydipsia, reoccurrent infections. They have changes in their vision. They have fatigue. They have decrease in energy. Their hemoglobin A1C is elevated. Their finger uh, blood sugars or finger stick blood sugars is going to be over 126. I'm sorry, so that's your fasting blood sugar is going to be over 126. They may have pre-diabetes, meaning that their blood sugar levels are between 100 to 125. And again, metabolic syndrome. So this patient hopefully is painting a picture of someone that is not healthy, someone that is not controlling those modifiable risk factors. So they have increase in their triglycerides, decrease in their HDLs, which is their good cholesterol. They have central obesity, that means obesity around their abdomen. They're sedentary, they're older, they're middle-aged, right? So this lady here is saying, I wonder if I have metabolic syndrome. Okay, so let's now continue with our discussion. Looking at the slide, we talk about, okay, metabolic syndrome. So this patient may have an elevated waist circumference, so indicating abdominal obesity, okay? So if your abdomen for women is greater than 35 inches, for men greater than 40 inches. They have elevated triglycerides, and that's going to be over 150. They have reduced HDLs, okay? For men, that's going to be less than 40, and for women, less than 50. Elevated blood pressure at or above 130 or 85, and they have a fasting glucose indicating insulin resistance, okay? And that's going to be 100. So again, this patient may have metabolic syndrome. Okay. So let's talk about, well, there's a lot of dangers that go with metabolic syndrome. And the big thing is to teach our patients to avoid this by becoming active, having a healthy lifestyle, eating healthier foods. And, they can't necessarily or won't necessarily change everything at once, but start them off with small changes like smoking cessation, following a DASH diet, drinking more water, getting up and just walking, once or twice a week, and then they can increase it to 3 times a week to the point where they're exercising or walking every day. So these are things that you can, help your patient with teaching and help to get them up and moving. Okay. So when we talk about diagnostic tests, these are the tests that will be done for our cardiac patients. Chest radiography, right? So we can have an x-ray done, chest x-ray, taking a look at the everything in the chest to include the heart, the lungs, the thoracic cavity. They can have nuclear imaging tests. They can also do a stress test, and the next slide shows you a picture of the stress test. They can have an echocardiography done with a scope that goes down through the mouth, through the esophagus, where they could actually get a reading of the heart. So they can have angiography, an MRI done, arteriography. They can do electron beam, computed tomography for coronary artery, calcium scoring, and they can do a stress echocardiogram, and they can do cardiac monitoring. So there's a lot of different tests. What you need to know is not necessarily memorize all of these tests, but when you see a test, you have to know that if the test is an invasive test, We must make sure that we have signed consent. The patient has that consent. The procedure was explained to the patient by the medical doctor. And our job as the nurses is to make sure if the patient has any questions, we call the doctor back to have them explain again. And we also will make sure that that informed consent is scanned into the patient's medical record prior to the procedure. Okay, that's going to be really important prior to the procedure. Okay, so here's a cardiac treadmill stress test. So I've seen this one a lot on, NCLEX questions because the patient teaching is come in for this test dressed in athletic gear, so shorts, sweatpants, something that they can move comfortably, tennis shoes, running shoes, because they're actually going to be walking and maybe even jogging and maybe even full on sprinting on this treadmill as long as the patient can tolerate. Now, they will elevate incline. They will increase the incline for this test. And while this is going on, there's different probes there's actually sensors that are placed on the patient's chest, on their arms. So we are monitoring their heart. As they have increase in intensity, and they are pushing the heart to its maximum capability during this test. Now, this is a mechanically or physically induced stress test. And again, they must wear loose, comfortable clothing because it's going to be like they're working out. Now, if a patient, for whatever reason, has like knee issues or they can't physically do this, and not everyone has to run, if you can walk, you can do this, and it's just the incline is going to get steeper. But if they're not even able to do that, they can chemically induce the stress test. So that's an important point to note. Okay, so if we are looking for specific vascular disorders, there may be specific tests. So it may be looking at a complete blood count, looking at which is called a CBC. So we're going to be looking at the red blood cells, the white blood cells, the platelets, looking at the electrolytes. Urinalysis wise, we're looking to see, if there are any abnormalities in the urine. We're looking also at blood lipids and cholesterols. Um, Also, they may do a Doppler flow study. Whenever we use a Doppler, that allows us to see the blood vessels. And they may perform an angiography, and they also may use nuclear medicine scans. Okay, nuclear medicine scans. So when we think about uh, one of the other tests is going to be the ankle brachial index. And so this is what they do is with this ankle brachial index, it's really an inexpensive kind of test and it's a non-invasive screening. And what it does is evaluate the arterial status of the lower extremities. When we think about arterial status, we're going to see how well are our arteries doing in our legs and our feet. Okay, so for this ankle brachial index test, a regular blood pressure cuff is placed above the malleolus, and another blood pressure cuff is positioned over the brachial artery. So a Doppler probe is used to check the systolic endpoint at the dorsalis pedis and the posterior tibialis sites. The brachial blood pressure is measured, and then the ankle brachial index is calculated by dividing the ankle pressure by the brachial pressure. Okay, an AIB of 1 or more is considered normal. An abnormal AIB indicates arterial disease and can confirm a vascular cause for ischemic pain in the legs at rest and claudication or cramping when they're walking. So when the patient is ambulating, if they have an arterial insufficiency, meaning that the arteries are not providing enough oxygenated blood, they may have pain when they're walking, and that is intermittent sometimes. So it stops when they stop walking. That is called intermittent claudication. So claudication referring to the pain that they experience. Okay. So you may hear the term, well, what is your claudication distance? Well, how far can you walk before you start experiencing this pain? Okay. All right. So for cardiovascular wise, what you need to know about nursing management is dyspnea. Difficulty breathing, that's going to be a priority. Yes, we're going to manage the patient's pain, but dyspnea, difficulty breathing, is a major symptom. It's going to be a priority thing that we need to act on. Now, African Americans most often experience dyspnea as an acute symptom during an MI. Okay, so dyspnea is more common than more classic chest discomfort. Okay, and so sometimes people may delay getting help because they're like, oh, I just have a little bit of difficulty breathing. I should be okay. Okay, so the patient again may complain of chest pain. This is the worst pain that they've had, substernal crushing pain. It feels like an elephant is sitting on my chest. These are all things that the patient could say when we're talking about gathering information about them. Okay. We will perform a focused assessment. A cardiac focused assessment is always going to be a good thing to do. Making sure that we're auscultating, listening to the four valves, not only with the diaphragm of our stethoscope, but also with the bell. We're going to auscultate down the mid line, and we're going to be listening for any bruits. Okay, any whooshing sounds, because that may indicate an abdominal aneurysm. Okay, so we're also going to be looking at the fingers, we're looking for evidence of clubbing. We're going to be checking capillary refill. So there's a lot of different things on this focus cardiac assessment that we would have to take a look at. Okay, so here's a question for you. Okay, which statement regarding drug use and the risk of cardiac disease is true? We're going to select all that apply. So is it one, vasodilation effects of cocaine hasten atherosclerosis? Well, actually, uh, no, because vasodilation will actually open up those blood vessels. So I don't like one. Two, sudden cardiac death is associated with cocaine use. Yes, that is true, unfortunately. So two is correct. A lot of times, if it's a person that is abusing cocaine, if they have cardiac death, it's more than likely due to the cocaine use. A lot of celebrities have experienced this. Those that have overdosed. Okay, that's how they usually die. The overdose, especially in cocaine, will cause sudden cardiac death. Okay, so two is correct. Three says methamphetamines dilates blood vessels. So that's not going to be a cause of a cardiac issue, the dilated blood vessels. Okay, that's not going to be correct. Now, four, cigarette smoking contributes heavily to heart disease. That is true. Okay, we know that for a fact. Okay, cigarette smoking is never good for your patients, and just as a general rule. Okay, number five, methamphetamine potentially causes MI. Okay, and that could be true. Okay, that could be true. So the dangers of substance abuse, okay, they are pretty real. So for this question, the correct choices are 2, 4, and 5. 2, 4, and 5. Okay, let's take a look now at common problems of patients that have cardiovascular disorders. They can have fatigue, they're tired, dyspnea, difficulty breathing, fluid volume overload. So fluid overload, that's your right-sided heart failure patient, your left-sided heart failure patient. They can have pain, they can have altered tissue perfusion and impaired tissue integrity. Okay. Um, so some other things to look out for your cardiovascular patients, if they're gaining more than 2.2 pounds in a 24-hour period, that is a cause for concern. Usually that tells us that 2.2 pounds, that tells us that they have gained 1 liter of fluid, and we have to figure out where that fluid is. Is it in their lungs? Is it around the heart? So that's going to be really important for this patient to be on I's and O's. Okay, so other things to think about when we have cardiovascular disorders, we want to make sure that these coronary arteries, which are responsible for getting blood flow to the cells of the heart, to make sure those coronary arteries are patent, they're open, they're not, all filled up with atherosclerosis. That could be a problem because that's going to cut off circulation or blood flow to the cells and tissues of the heart. Okay. We are also looking out for this fluid overload. It makes me think of your left-sided heart failure. That's going to be you want you to think left, think lungs. Okay, left, think lungs. Okay. Okay, so here's question number 2. Okay, question number 2. Okay, if a patient complains of moderate chest pain, an appropriate interview question would be, and you're going to select all that apply. Who witnessed the pain? What does the pain or discomfort feel like? What relaxation strategies were implemented? Where is the pain located? And where does the pain radiate? Okay, so the correct answer choices are going to be answers 2, 4, and 5. Okay, so we need to figure out, what does the pain feel like? Is it sharp? Is it dull? Is it like a pinch? What is this pain feeling like? The next answer that is correct besides 2 is going to be 4. Where is the pain located? Okay, show me, point to where the pain is. Number 5, where does the pain radiate? Does it spread? Is it a referred pain to the jaw, to the arm, to the back, to the neck, to the left side of the body, right? So where does the pain radiate? All right, so this concludes the discussion of this chapter. I hope you enjoyed it. Thank you so much.